Hi, everybody. Welcome to this month's Cord Connects. We are going to get started with Mary Ann Howie.
Good afternoon. Welcome to Cord Connects. My name is Mary Ann Howie, and I'm a member of the Cord Board of Directors. I'm joined by my partner, Moshe Weisberg, who's also a member of the Cord Board of Directors, and I would like to welcome you to Cord Connects. Our session today is on maximizing your CCC. I would like to introduce our speakers. We have two speakers today that'll be sharing the talk. We have Holly Caretta-Weyer and we have Scott Leuchten. Dr. Caretta-Weyer is the Assistant Residency Program Director and the Director of Evaluation and Assessment at Stanford University. She's also the primary investigator on the AMA Reimagining Residency Grant, looking at changing our approach to assessment and individualized learning in competency-based systems across all of emergency medicine. You can reach her on Twitter at @Holly_CW. Scott Leuchten is the Associate Program Director of the Emergency Medicine Program of St. Barnabas Hospital in the Bronx, New York. He is the chair of the CCC for the Department of Emergency Medicine for St. Barnabas, and he is on faculty for CUNY Medical School.
Great. Thank you, everybody, for joining us this afternoon. We're honored to be giving this talk about maximizing your CCC and developing a program that doesn't just meet the basic requirements, but also enhances the output for your program and for your residents. Okay, just to go over disclosures, we have no disclosures, no financial disclosures. We just work in our spare times, but nothing else to discuss here. The agenda here is going to be kind of 4 to 5 parts. We're going to identify the purpose of a CCC. We're going to discuss the rules and requirements to stay in compliance with ACGME regulations. Again, that'll be the basement floor of what you need to do for your program for your CCC. And then we're going to discuss different tips to improve your CCC and discuss some common pitfalls. And then at the end, we'll provide some time for some questions and an opportunity to ask us anything that we brought up during the talk. So I'm going to start here by kind of labeling the definition first, right? So what is a CCC? It's a required body comprising 3 or more members of the active teaching faculty who's advisory to the program director, reviews the progress of all residents in the program. So again, this is talking about the floor. This is what your basic is. This is what I need to do. This is a checklist of what I need to make sure that my program has for my CCC. Obviously, there's plenty of ways to bring this, and Holly and I are both going to argue that in many ways the CCC is a fantastic opportunity to really create beautiful assessments of your residents. So how do you stay in compliance? How do you stay out of trouble? What needs to get done? So the first is, where do we come up with this information? Where do we get this information? And in front of you is a slide shot from the ACGME, which is the Clinical Competency Committee. It's a guidebook for programs. This is the 2nd edition. This was published in 2017. It's approximately a 74-page document, actually. It's pretty long, but it answers all your questions. It even actually has a self-assessment quiz in the back, so if you want to test your knowledge about CCCs. And it provides basically all your foundation for what you need to do. The other places you're going to go is your common program requirements for residencies from ACGME, and also obviously for the program requirements for emergency medicine. And you'll find both of those on the ACGME website, and that's where you're going to go for these criteria. So what are the 4 things that kind of have to be done? What are the 4 things that are mandated is for your CCC? The first is the program director must appoint the CCC. So your program director appoints the Clinical Competency Committee. You have to have a minimum of 3 faculty members. It must have a written description of the responsibilities of the CCC, so somewhere, and that should be reviewed probably every year. And then the 4th requirement is it should advise the PD regarding progress, promotion, remediation, dismissal for all the residents in the program. And so if you have those 4 components, you're likely in compliance with the basics of the CCC. Just some quick questions about what else is brought up there. So how many meetings do you need to have? It doesn't necessarily state. Obviously, milestones, which are help to be completed by the CCC, has to be filled out semi-annually. And a survey, Dr. Doty and others, they looked at 116 emergency medicine programs, and a little over 50% of them met quarterly, and a third of them met monthly. The others had some variation of the above. So who's in charge? Generally, the program director should not be in charge of the CCC. Again, the CCC, the program director has the final decision on a resident's progress, on their progression, on any disciplinary actions. And so they're the final decision. This serves an advisory capacity. So ideally, the program director should not be the chair of the CCC. However, the chair of the CCC should be experts on the milestones. They should be experts on doing proper evaluations, and they should be experts on running an effective meeting. So where does the PD fit in? Different programs will have different kind of requirements for them. I know at my program, the program director sits, listens, will then discuss after the discussion of each resident, and then can serve as advocate if the CCC has some concerns. How many people? Again, the requirement is 3. You don't want more than 10, and in fact, in the CCC, in most the literature, it'll recommend you want between 5 to 8 people for your CCC. Residents shouldn't be part of the CCC unless they've graduated and they're part of like a fellowship program affiliated with your institution, but they should not be part of the CCC. Unlike in the PEC where you need to have residents, the CCC should not have residents. And finally, for documentation, the ACGME doesn't state or highlight necessary documentation. You do need to have the meetings and demonstrate that. The one area that they do point out to is that in case of disciplinary action, you need to demonstrate academic due process. And those 3 kind of things that are important is for residents, notice of deficiencies, opportunity to cure those deficiencies, and then careful and deliberate decision-making process. And this is where a CCC and the deliberation process, where you might have to demonstrate that if you're in the unfortunate position of having a disciplinary action against a resident or somebody fighting a disciplinary action against the resident. So that might be where it's important to have very good documentation, especially of the minutes and the deliberate decision-making of the body about any actions. So that reviews the basics, that reviews the requirements that the ACGME lays out, and we're going to turn it over to Holly for a little bit. Oh, that was amazing.
Would help if I unmuted myself. So why do we care about kind of going above and beyond the requirements for a CCC? We talk a lot about competency-based education and where we're headed, and I think we can all agree at this point this is the future. The International Competency-Based Medical Education Collaborators have set forth the 5 core components for competency-based education. Elaine Van Mel's paper finally was published, but this has been on the ICBME website for a while, and this is what we've been working off of. We have an outcomes for competency framework, which is the competencies and milestones for emergency medicine. There's sequential development along the milestones. We're working towards learning experiences tailored to the competencies and teaching tailored to the competencies. But the CCC's real work is programmatic assessment. So what does that mean for us? It means that we need to be looking at multiple points of assessment by multiple different people using multiple methods over time. So, for example, this can be multi-source feedback from nursing, pharmacy, social work, techs, patients. It can be workplace-based assessment from your faculty, global ratings, simulation-based assessment. All of these things are giving you your multiple modes of assessment. And if you have multiple people looking at them and looking at the learner and giving you data, all of this should feed back to your CCC. There should be an emphasis on actual demonstration of ability in the workplace, an emphasis on providing feedback directly to the learner in real time as often as possible, as well as the information from the CCC being not only used for decision-making, but also direct feedback to the learner. So this is how the ACGME actually demonstrates that in the guidebook. They give you this crazy diagram. They say, this is what programmatic assessment looks like. Average people look at this and they're like, this is difficult to understand. I'm going to break this down for you to being, here's your program of assessment between the residents and the faculty, and it's this shared system that gives outputs to all stakeholders, being the residents themselves, faculty, program director, CCC, the ACGME in the form of milestone reporting, and even to other people outside of the CCC. which is really what this breaks down to. It's just that your program gives all of this data to all of these people and helps the CCC make judgments by synthesizing all of this data. So I want to break this down into, the CCC has two key purposes. There's assessment for learning and assessment of learning. So obviously the CCC has the distinct output of giving, making decisions about whether learners can move forward, whether they can graduate, whether they need to be remediated. However, that doesn't happen in a vacuum. There should be output from the CCC directly back to the resident saying, here's the areas we think you need to work on, and a coaching relationship where they can say, here's what I see, the CCC sees this, and someone to help them synthesize that into an actual actionable learning plan. So what does the CCC actually look like these days? This is the dreaded hallway. I think all of us know that we have so many conversations with people in the hallway that are never documented. They end up in the CCC and you don't know what to do with them. You know that some people think something about a learner. You know that other people probably think that too, but you don't have any sort of documentation, and faculty are often afraid to provide this feedback directly to the learner or write it down because of retaliatory feedback that affects their promotion. Or they think it's a one-off and they don't want to be the person who, you know, ruins that resident's chances at progression or causes them to be on remediation. However, I think we all know that we need to move our CCC out of the hallway and into a space where everything that we do is documented so that we can actually use it to provide feedback to the residents as well as make decisions, and make decisions that we can actually back up. The other thing is our CCCs often look like this, meaning that we have all of this data and it's all in disparate places and not everyone has all of the data. So a lot of people are playing with half a deck of cards, and people on the other side are saying, I'm hiding my data from you, I am the only one who owns this, or there's just no way of sharing it, or it's still all on paper. I would argue that we should have a robust way of sharing this data and visualizing this data so that it can facilitate the discussions that we need to have as a CCC. It can facilitate individualized learning plans for the residents, and it can facilitate us making actual defensible decisions. And then finally, I think our CCCs often focus on the black sheep, the residents who are in difficulty, where we often don't talk about the residents who are excelling or are doing just fine. I think it's important that we at least give credence to everyone. And as we move forward and ACG begins to require individualized learning plans for everyone, I think we're going to have to learn how to identify the areas of need for improvement for all of our residents, as well as be able to push them forward in their careers, in addition to identifying those learners in difficulty and helping them progress as well. So we're going to cover some best practices for how to not just do the bare minimum and not continue with the status quo, but also start doing some of the things that we really want to be able to do to improve our CCC and provide meaningful output for all stakeholders.
Yeah, so most of our next, we're going to go through kind of 12 tips to maximize your CCC. And when Holly and I were discussing where to get this from, this paper, I think, summarizes it fantastically and gives you 12 different things. And the second time I read this paper, I actually used it as almost a report card for RCC. And I said, do we meet any of these or do we not? And so that way it provides places to improve and some best practices. So the first one, the first step, and it's the why are we here? Why are we sitting down and why are we doing this? So it's define the committee's guiding purpose. And you can have different purposes. ACGME writes that the CCCs is to demonstrate accountability as medical educators to the public, that we're graduating high quality physicians that will provide safe care to patients. My CC says that we're going to create a well-informed, well-discussed, and well-supported evaluation and plan for the development of each of our residents. And so the first thing you want to do is you want to create this guiding principle. So that way everybody on your CCC knows, why are we here? What are we doing? Yes, there are requirements for ACGME, but what are we going to do and how are we going to spend our time in a way that's useful for our residents and for the program? And so the first is, I would argue, you have to define the committee's guiding purpose and make sure that everybody is aware of that, that's sitting in the room with you.
So the second is to actually identify and collate that data from multiple assessment sources. So we talked about programmatic assessment. That's what we're talking about here. So you have each of your residents. So I have 61 residents, and I'm going to have multiple data points for all of them from all of these different sources. There has to be a way to actually put all of that data together and look at it and use it in a meaningful way. So be that an Excel spreadsheet, be that a more robust data management system, there needs to be a way for you to take all of that data and put it into a meaningful and usable form so that you can see it when you're going through and reviewing as a committee. If you have data points in MedHub, you have data points in Excel, you have data points in another learning management system, it's very difficult to get all of that data in the meeting and share it with each other, as opposed to having it all in one place or one way that you can just visualize it in aggregate to be sent out to the entire committee. The way we do this is we have all of our milestone data input into a spreadsheet tagged to all of our different assessments, and this, along with the comments, is distributed to the CCC. We're in the process of developing a learning management system to actually visualize that data. So that's one way to consider it, but it doesn't have to be this advanced, super techie way of doing it. Any way to actually be able to share that data and visualize it so you can make decisions is of utility.
So next is going to recruit the right members. We talked about before that you need to have more than 3. Most of the literature will say that to have an effective group, you want between 5 to 8 people. But rather than just having butts in the seat, what do you want in these members of the CCC? First, you want diverse opinions. You want people from your higher education or your residency leadership team. You want people who are line attendings in your department that might be core faculty or work with your residents quite often. And you want your section leaders. So you want to know, you want the ultrasound director or somebody from the ultrasound department who can help you with that milestone. So you want diverse opinions. You also want dedicated people. Often, as Holly said, there's many different assessment tools that are used, and there's a decent amount of pre-work that goes into each CCC. So you want to ensure that those members on the CCC are doing their pre-work, and they're coming to you, whether they're presenting a candidate or the resident, or whether they are going to be in charge of a certain milestone or not. You want to make sure that those members understand the mission and that they do the pre-work, and you want diverse opinions, so that way you can form a full evaluation of your resident.
So along those lines, once you have the right people in the room, you want to be able to actually train them to provide the output of the CCC that you're after. So you don't want to just have a bunch of dedicated people there who all have different ideas about what it would take to meet the purpose of the CCC. So you need to conduct regular training, be that setting expectations at the beginning of every meeting, saying this is confidential, this is the way the discussion is going to be structured. In addition to that, having regular training around what are the expected outputs of the CCC, be that individualized learning plans and how those are developed, the discussions that need to happen around those, or, each discussion needs to be X long and include X number of things. So for example, some programs have goals where they talk about the academic, clinical, and professionals and communication domains. So they talk about all 3 domains for each of the residents, be that before the meeting or after, or during or after. They have that as an expected output. So actually being able to train people to focus on each of those domains or focus on their specific milestones or a specific class, exactly how you want your committee to run and what you expect your outputs to be should guide how you train your committee to function.
Great. So step 5 is going to be develop methods for real-time sharing of assessment data during the CCC. As Holly mentioned before, there are many different evaluation forms. There are praise cards. There are sim sessions. Everything gets evaluated and it's put together. And you want to be able to share that. You've collected that data for a reason, not just to appease the the bean counters, but you want to use that data because that will create a more robust evaluation. So I think gone are the days where the program coordinator, brings in the resident files from the back room with all these evaluation forms filled in, and they're just sitting on the back. Maybe somebody will look at it, maybe somebody won't. But you want to have the ability to do real-time looks at the assessment data. So most of our evaluation software provides dashboards that can be displayed, whether they're an email attachment, whether they're in a projection over the meetings table, or some way that people can see what exactly went into the assessment, where all this data went. And then therefore you can also provide comparisons to other residents or other residents in the group, and you can also see where they were before. It also will let you do a deep dive if needed, if the CCC becomes a debate about a resident, and it'll let you do some deep dive. So it's really important that you have the ability to have real-time sharing of the data that you've collected, that's easily viewable, that's understandable, that really helps you form a diagnosis or form a evaluation of the resident in real time.
So establishing ground rules is key to actually having a functional CCC. Karen Howard, someone will work about group process, gives us some guidance in this realm where we talked about you need to have the right members in the room. There needs to be diverse opinions. You need to have the key stakeholders involved. I think that is key, but you also need to make sure that each of those people can be heard. So a lot of times your CCC will have the 1 or 2 loudest voices or the 1 or 2 most senior voices. Sometimes people don't feel comfortable speaking up. Sometimes people think that their experience is isolated to just them. You need to create an environment where everyone feels like they can share their opinions, share their experiences, and where you facilitate everyone being able to share. The goals that you have and the outcomes that you set for the CCC will also establish how your process works. So at the beginning of every CCC meeting, I basically say that, this is all confidential information. The goals for this meeting are whatever they are. So a lot of time it's to establish individualized learning plan goals based on our data for each of the residents, be that, 1 to 3 things for each of them, to discuss residents who are having difficulties and how they're progressing in their remediation. And then also to discuss a particular class more in depth. So those are some of the goals for our CCC. Other CCCs may have different goals, but establishing ground rules around that in a group process so that you can avoid hearing just specific opinions is important. Additionally, having each of your CCC members complete implicit bias training and calling out bias when you see it in the CCC, so you don't get into this groupthink around, this resident is doing XYZ thing, or this resident is XYZ way because one person says it and then people start glomming onto that idea, and other people who may not think that way don't feel comfortable speaking up. There needs to be a way for you to set ground rules to prevent that kind of thing from happening, because we've all seen it happen and it is very easy to fall into those patterns of behavior.
Dovetailing off that, one of the rules that I think is important is a structured format for the committee's discussions. I've been plenty of rooms where the resident's name gets called out and, it's like, oh, Scott Leuchten. Oh, great resident, wonderful, great. And before you know it, nobody has anything else to add. And that doesn't allow you to do your entire assessment, because you're done. You've said what the first thing that comes out to what comes to the evaluator's minds, the CCC minds, and it doesn't allow for different opinions. So I would argue that we need to have a structured format for committee discussions. If you have somebody do the pre-work or present the resident to the group, aka this is Scott Leuchten, he's a PGY2, he is last committee meeting we had these concerns, we had and these are the places he was doing well. Since then, the evaluations have come in that support that or disagree with that, or maybe this is where he's in his remediation. And that way there's a structured format. And then therefore you have the opening kind of everybody's on the same page with the data you've collected. And then you can open the floor to different opinions, to comment on what they've seen, what they've witnessed on their specialty area. or things that may have not been caught in an assessment. And then it allows you to complete the whole kind of discussion each way. And that way it prevents the great residents from being just labeled as great and moving on. It also prevents the troubled residents, or the residents that have some issues, from just being those bad eggs, and just reinforcing the bad. So therefore, you have a structured format for each resident that gets presented, and therefore you have a more equal process for everyone.
So employ strategies for time-efficient member participation. This is key, as the CCC, we all know, can be a thankless job, and some people don't find that it is worth their time, or they're appointed to the CCC. They don't think that spending an entire day talking about the residents is of utility. So that goes back to recruiting the right people, but also providing the time and the space for the CCC to do its work. So this may take the form of having groups meet beforehand and having experts in certain areas, be that a specific class, be that a specific set of competencies, be that a specific domain such as academics or communication professionalism or patient care. Those various things can give you the ability to have people meet beforehand, review all of the data in any of those domains or by class or by their competencies, and then bring that data to the group so that your group time is spent efficiently, so that someone is presenting the data and then the group is actually spending its time making the decisions and meeting the output goals, be that individualized learning plans or feedback to the resident in another way. Using your time efficiently helps members reinvest in that process, and also giving them a domain that they own helps them actually take ownership in the process and invest further.
The next step is that you want to integrate the CCC into a program of assessment. In some ways, the CCC is a great barometer of how well you're assessing your residents. All assessments come through the CCC. Therefore, they have the ability to say, oh, we have enough information about this milestone or about this, of this standard. But you know what, we don't have enough information on this. For example, RCC didn't have enough information recently about airway management, and we weren't getting enough evaluations of the residents doing their procedures. Sure, we had their procedure logs, but we didn't have evaluations of that. So we wanted to see how can we, so one of our steps was to say, program leadership, can you create more assessments of a resident's airway skills? And how can we do that? After intubations, after the airway lab, after the sim lab, how can we assess their airway? And that way we can do a better job of providing real feedback for our learners about how they're doing it. So we want to integrate that into the program of assessment. They have the ability to see where all the assessments are lacking. They also know what faculty provide great responses, and they can also allow you to find faculty that are subpar, and maybe they need some development in that area. And you can recommend them for different faculty development sessions on building their evaluation skills or their assessments or their feedback to the learners. So so the CCC not only gets all this data and synthesizes something, it also go back to the program leadership and say you need to do better in an area, or you're doing great in a particular area, but you want to integrate all this. You want to integrate the comments of the CCC into the program of assessment.
So having standard output for all of your stakeholders is key. So I think a lot of times we lose who our stakeholders are. So our stakeholders include the residents themselves, the CCC itself, the program, our faculty, and also obviously the ACGME. I think that's the one that comes first and foremost to all of our minds. So output for the residents can include things like learning goals or progress reports. Here's how you're doing. Here's the things you can work on. The ideal would be for them to synthesize what they think they're doing well at and where they see areas of improvement based on all of their data being available to them. And then having a coach say, here's the 30,000-foot view, here's the output from the CCC, here's how you're doing. We're going to synthesize the two of those to help you build out a learning plan. Output for the faculty, as we just discussed, can be things like, here's how your feedback is. So I've seen programs have it where they can actually, through their data aggregation system, say these are the number of words per comment, here's the rating of the quality of the comments, here's your direct feedback to the faculty, here's where you need to improve. Those are rare, but I think that's a direction that we've been heading. So output to the program itself is basically, here's how all of your residents are doing, here's all their learning plans, here's how you can keep track of them. It basically does the work of, here's the things that the ACG&E mandates that you do, but we're also giving you this additional information about your residents so you can carry this forward and actually have a direct learning plan for all of them to individualize their professional development. And then the CCC should be looking at the data too, saying, this is how we're doing, here's how we can improve. And finally, the obvious output is the ACG&E milestones reported to the ACG&E biannually. That is partially the work of the CCC, but that doesn't necessarily need to be the focus of the meetings themselves, as long as you have the ability to aggregate that data and output that information.
So you want to have a standard framework to provide feedback and performance for the residents. So one of my joys actually in chairing the CCC is creating a plan for the residents on how they're doing and what they can do better and what the next goals for the next few months are going to be. And so, but however you want to standardize that, right? So again, we talked about some residents will be the great ones and they won't get things they need to improve on. And the people that are having some difficulties, they'll only get what they need to improve on and not focus on things. So you want to make sure that you now have all this information, you've got this report, you've got however you put it together from the CCC to go back to the resident. How do you provide that back to the resident? So you want to tell them in person. It should be from an advisor or a coach, an APD that's kind of in charge of them, that's not only understands the feedback that the CCC provided, but understands about how the resident is developing, how the development of the resident is going, and where they want to be. And so then you also want to do it in a standardized way. So there's different methods. There's the R2C2 and the SMART methods, which can help provide feedback or a rubric for how you present data to the resident. One of the things I like to always ask when I do these meetings from the feedback is to ask the resident for a self-assessment, to say, where do you think there may be issues, or where do you think the CCC plan is going? And that way I know where they are. I think one of my favorite evaluation forms is the self-evaluation. And then I also have them, when they sit down with me, if I'm in that role of their coach, to say, where do you think you're doing well? Where do you think you're doing poorly? Where do you have to do better? And then I can tie that into what the CCC provides, and providing the standard framework so every resident kind of gets that coaching session in person, somebody who understands that, who's their advocate, and that can interpret the data from the CCC for them, and providing that feedback for them.
And finally, you want to be able to engage in continuous quality improvement of the committee. I know we all love program evaluation and discussing the things that as a program we're doing well and potentially not doing as well, and drawing fish diagrams and all of those things as part of program evaluation committee. But that's some of the things that you need to think about with your clinical competency committee as well, because it's not just a set it and forget it kind of thing. It evolves over time. It's a living organism. So things with the clinical competency committee may change. Members change, goals change, outputs change. There are going to be things that you need to reevaluate on a regular basis. And having a growth mindset around, there's always room for us to improve, we're going to fail, and failure is okay as long as we learn from it. I think that is important. Also, looking at how you make your decisions is key, because the information you need to make your decisions may not be complete. And identifying gaps in your program of assessment and filling them, or owning that they are gaps and finding ways to actually make decisions that you can stand behind in other ways, is also part of your continuous quality improvement process. You want to be able to make defensible decisions. You want to make decisions that you, your residents, ultimately society can trust. And so the responsibility of the CCC is big, and making sure that you're doing your job in a way that you can defend, in a way that makes sense for your residents and your other stakeholders, is extremely important. So with that, those are the 12 best practices that we wanted to cover. You can find this paper, it's 12 tips in Medical Teacher about your clinical competency committee. Ben Kinnear is the primary author. And it's something that you can use as basically an additional kind of best practices guidebook for your CCC. And hopefully we have questions we can answer at this point.
Excellent. Hi, I think, are you guys able to hear me again?
Yes.
Okay, great.
Yep.
So I just want to point out to everybody, there's a little chat box at the bottom of your screen on the Zoom screen. So if you have questions that you would like us to forward, or you would like me to forward to the speakers, you can feel free to type them in. Or if you want to ask a question, I think we can figure that out with unmuting as we go along. I do have a question. I think it becomes interesting when you end up having a voice that is both dominant and negative in the group. It can be very challenging to funnel that person so that they're giving productive feedback, as opposed to kind of being a Eeyore about residency education sometimes. And often that person may be senior enough that, removing them from the group is unreasonable and not feasible. How do you find it to be effective to kind of redirect that person and their efforts within the group of the CCC, and what are some tricks you can do for that?
Yeah, I think part of it goes back to making sure you have a standard format of how you kind of present each resident, right? So especially, and I think Marianne's right, generally the person, this is one of the senior leaders in the room that everybody might be a little afraid to offend. So if you have this standard format where you get your assessments, you have your evaluations or your averages of your assessments and where they work among the other residents in the group, you then will open the floor to different opinions, and that opinion will come out, but you have the opportunity to kind of I don't know, diminish it a little bit because you have the standard format that everybody kind of has to follow. I don't know, Holly, other ideas?
A lot of strong personalities on our CCC, which I very much appreciate. I think for me, it's always validating that person's opinions and saying, thank you for sharing that. I really appreciate your perspective. I would like to also hear from everyone else in the room, because I think everyone has varying experiences, varying opinions. And yeah, I agree. Having a standard format for you have somebody present the resident or present their competencies, whatever your standard format is. And I think going around the room and saying, we've heard from these people, I'd really like to hear from everyone else, is extremely important, and just creating a safe space. I think psychological safety we talk about a lot in the learning environment for our residents. We don't talk about nearly as much for our faculty, particularly around the Clinical Competency Committee, the Program Evaluation Committee, other things that people may perceive as being high stakes for them as faculty.
Dave Gordon typed a question that says, and Dave, if you want to unmute to clarify this, that'd be great. But what is your opinion on dividing a program CCC into years? There we go. There's something else written there. In other words, a CCC for year one, a CCC for year two. Dave, what I'm wondering from your question is, do you mean that you would have a different group of people for each year? Like, attending A, B, and C do PGY year one, attending B does PGY year two?
Yeah. Can you hear me okay?
Yes. Yeah.
Hey, David.
Hi. Thanks for your presentation. Yeah, so I'm asking based on what we do here. Like, we have a chair of a CC1 committee, a chair of a CC2, and a chair of a CC3. Those are standing chairs that always kind of sit on that committee and become very familiar with that year's work. And then we have rotating members that actually follow that class, and they'll follow the first year class when they become second years, and then follow them become third years, and we'll go along the different committees. But it kind of divides the work and makes meetings manageable. So I was wondering if you had seen that model and had any feedback on that model.
I have. We don't follow it here, but I have it a prior institution. And I think it works really well, having someone who knows that's like what that class is supposed to be achieving. Like the PGY2s are generally in this vicinity at this point in time of the year. And then having people who actually know the individual members of the class, I think is also really helpful. I always want to set ground rules around like, you know, you clearly know and love this class, you're invested and want them to succeed. But you have to also remember, you know, you're here to also make them better. And I think that's something that our group has been talking a lot about recently is how do you actually combine coaching and assessment in the same vein, because you have to know how they're doing. But as a coach, you also still are invested in seeing them succeed, and you don't want to have to be the one to deliver the news that maybe they're not quite making the cut in a certain area. So I do like that, because you get a little bit of a flavor of both by having people who stick with the year and people who move with the class.
Yeah, I think if you have the faculty buy-in, I think that's great. And I think as long as you have the continuity part, as long as somebody is following these residents so that they're aware of, maybe they had some issues in PGY1 level that the PGY2 CC committee might not be aware of, that highlights that they, you know, they're making progress, even if it might not be to the standard yet decided by that group. But I think that's a good idea. I've never heard that one before, actually.
Thank you.
And I'm going to apologize because Sarah, I'm gonna blame my, thank you for sending that.
I got you.
I'm gonna blame my old eyes on that one. Said we have a tool for every single milestone, but it becomes tedious. In attending sessions about CCC at other conferences, it seems some programs still fall back on Gestalt. My interpretation of the CCC was that it was designed to help us move away from the Gestalt, the resident, quote, the resident is fine. Any perspective on best approach to the specific assessment of each milestone, and how many of your milestone subcomps are evaluated by Gestalt?
Sarah, that is an excellent question. Okay, so I'm going to answer this in a twofold kind of way. So we have evaluations where different faculty get different subcompetencies based on their area of expertise or things that we feel they're in the best position to assess. So we have 7 different assessment forms that go out to the faculty, and each question is tagged to milestones. Some cover multiple, which we're trying to get away from, but they're, you know, the faculty each get their own set. So we get numerical data on each of the milestones. I don't necessarily think that it's the best format, but it's a format where instead of slapping the milestones on a piece of paper, we actually send out things that are asking targeted questions about, do you think they're where they're at with, where they're supposed to be at with regard to this thing. I still find the narrative comments to probably be the most helpful. That being said, shameless plug for the AMA Reimagining Residency grant that we're working on. We're gonna be moving to more of an EPA-based system where the milestones are tagged to the EPAs, and the system becomes more intuitive for frontline faculty to be giving assessments, and then multi-source feedback and all of these other things to make your program of assessment more streamlined and easy to use. The other piece of this that I want to talk about is in competency-based education, the traditional psychometric properties of like validity and reliability aren't necessarily going to be the same that you would expect from like, you know, your traditional frameworks of validity, like not MESIC per se. Because I don't know that you're going to be able to say that every single faculty rater is going to see every single resident supervisory level as the same, or every single narrative anchor as the same. So that is where expert judgment actually plays a significant role in competency-based education, and getting the right people in the room to have those discussions around robust, both narrative and quantitative data is really, really important. And he wrote a paper, Leuchten wrote this paper, I think, within the last year, and I will try to pull it and put the reference in the comments.
That's excellent.
Can I ask a follow-up question to that then?
Of course.
Holly, how do you guys send out those forms to your faculty? We did something with paper and we drowned in paperwork. We've tried to do it through New Innovations. We send out milestone-specific evals through New Innovations, but it's really hard to see any comments. We can see yes, no data very easily, but those comments get lost. So do you guys have a system that you use for that?
Okay, so caveat. We use MedHub. I don't love it. The evals go out and the faculty are just required to do X number per month, which defeats the whole real-time real-time feedback purpose, which is why we're trying to go more towards an app-based, like 2-question plus narrative comment system. But our MedHub evals, the narrative data is actually right at the top. So you have to address that. Most people will address it first because they'll go in order. So it's, you know, how do you think the resident is, what do you think the resident is doing on their best day, and what feedback would you give them? Like, how would you ask them to improve if they were taking care of your family member? Like, those are our basic narrative boxes. And we get so much robust data out of that I tend to just use the milestone reporting data to see if they're falling off the curve and for reporting purposes. Most of what we talk about in the CCC comes directly from those comments or from the secure emails or hallway conversations, which at this point I've taken to literally emailing to myself and the person who's talking to me to say, we had this conversation. Now I'm documenting it. I'm not gonna say it's a perfect system because it's not, which is why we're trying to get away from that and do this daily, easy, approachable, like, here's the level of supervision for this thing, here's the comments, and then residents are getting feedback every day, faculty are giving feedback every day, and it just becomes this normalized thing where no one's gonna retaliate for one data point out of hundreds, as opposed to this, what feels high stakes because it only happens once every couple months.
Thank you.
Any other questions out there? Well, I really want to thank our presenters.
Marianne, can I squeeze in
Yes.
one more question?
Oh, yes. Hi, sorry.
I couldn't, it's Dave again. I couldn't type fast enough. How do you guys handle the situation where comments come out in the meeting? So like someone may have a memory in their background. They didn't put in MedHub or whatever. But then in the discussion, like, oh yeah, I had that experience too, and that experience too. And it can create a little bit of a rolling ball effect. And do you capture that and consider it evidence, like by documenting and needing notes? You also worry about, you know, becomes a little bit hearsay. So I'm just like, sometimes discussions come out and you're trying to figure out what to do with those comments. And does that kind of make sense? Like,
Yes.
how do you, yeah.
Scott, how do you handle this?
Yeah, no, I was. This happens quite often, right? Where somebody brings up something and then everybody will add on. I think there's kind of two. I'm trying to judge my answer here. I think part of it is if we see a repeat, if people have similar comments to that, we will bring that up. If it's a one-off, like, oh, I had a really bad shift with somebody, or they didn't do really well in that one day, or this particular area they seem to be pretty poor at, and nobody kind of correlates that, we might write it down for later, but not in their formal evaluation. If it becomes to look for patterns. If it becomes a rolling ball, we will put those in the notes because we understand that maybe some of the evaluations that went out didn't either touch that situation, or they felt like they couldn't talk about it in the evaluation because the residents can review that. So if it's definitely shows repeatability, we will put that in our notes and put that in an evaluation or report back to them.
Yeah, we approach that similarly, where if it comes up in the meeting and it seems to be an experience that a lot of people have had, or it represents like a pattern of behavior, like it's happened before, now it's happened again, or something similar, we'll put it in the meeting notes and it will go into their individualized learning plan. If it's a one-off, we put it in the notes and don't necessarily address it unless it comes up again, or if someone else can corroborate it. I think documentation is key.
Yeah, and then documentation is important. And I agree. Usually that one comment comes from that the senior guy in the room, or senior woman in the room, and the kind of the more line docs or the people that work kind of more with them won't necessarily see that. So we'll write it down to make sure it doesn't become a pattern, but not necessarily report it back to the resident if it doesn't turn into a pattern.
Does anyone else have any other further questions? I really want to thank both Dr. Leuchten and Dr. Caretta-Weyer.